Can we just change the, thank you very much. Thank you. Right, with it now being just on 6 o'clock, I believe. I think we are ready to commence unless anyone tells me otherwise. Right, thank you. Well, it is my privilege to open this webinar, which is the inaugural session in Telecare's Year of Education. We've got two very topical clinical presentations, one on headache and the second, infections in the return traveller. But let me first acknowledge the traditional owners of all the various lands on which we meet today and pay our respects to elders past, present and emerging. To introduce myself, I'm Robin Mason. I, like most of you, all of you, am a registered medical practitioner. I've had a varied and challenging career in healthcare leadership, including 15 years with the AMA, initially as CEO of AMA Victoria, and then Secretary General of the Federal AMA in Canberra. Currently, I serve as a medical member of VCAT, largely hearing medical board referrals for professional misconduct or doctors' appeals against medical board decisions. And most relevant to this evening session, I serve as chair of Telecare's Clinical Governance Committee, a role which I take very seriously. Over my extensive career, I've seen the best and I've seen the very worst of Australia's healthcare system. And it is with great satisfaction that I observe and applaud the dedicated manner that Telecare goes about ensuring the facilitation of top quality healthcare systems and their various services. The provision of CPD sessions such as this and the fact that they are credited for points with the RACGP is just one example of Telecare's quality service commitment. So our first session this evening promises some very practical guidance for us all. As registered medical practitioners, we are all being moved onto this new era of compulsory CPD in accord with the new CPD registration requirements. Fair to say that this standard is somewhat more demanding than what we have experienced in the past. We're therefore pretty fortunate, very fortunate this evening with a presentation from, dare I say, the guru on CPD compliance for general practitioners. And I have great pleasure in introducing Sharon Safstrom. Happy to be called the guru, I hope, but certainly I think deserving of such a title. Sharon is CPD Engagement Manager at the College of General Practitioners, the Royal Australian College of General Practitioners. And I think I'm right in saying that tonight you're all the way from WA?
That's correct, yes.
Absolutely, but we won't hold that against you. Just one more quick piece of information. I think Ray has already put this up in the chat facility, but if you have questions, please use the chat icon to record any questions. I think there's a question 1 too, isn't there? But anyway, put your questions up in a written format. And during the sessions, the 3 sessions, first of all, starting off with Sharon's, we'll do our very best to ensure that those questions are incorporated, or the answers to those questions are incorporated in the presentations. Realistically, we may not be able to do that because time may not permit, but in that case, we will do our best to get answers to those questions and forward these along with any links that the presenters may refer to during their presentations. We'll do our best to send those on to all. Thank you, Ray. The Q&A button is at the bottom of the screen. And so we'll do our best to make sure that everybody gets all the information, including answers to the questions. Just another comment about that question button. It actually, in my experience, works very well. If you think it is a very relevant question, then you just like it or you just tick it, and then it gets an extra point recorded against it, and it's elevated to the top of the screen, which means that it's got greater chance of being answered in the time that's permitted. So that's all I have to say. As I say, I'm very proud and very happy to be introducing this session. Great work that Telecare does, and great work, obviously, that the Royal Australian College of GPs does, which leads me on to once again introduce and hand over to Sharon. Thanks very much, Sharon.
No worries. Thank you, Robin, and thanks for Telecare for having us today. I am coming from WA, so it's a bit earlier in the day and a little bit warmer, I think. I'm just going to share my screen. But as Robin said, we may not have time to answer all of the questions, but what I will send out to Telecare that they'll pass on is some links, some tips and tricks, and who to contact afterwards as well. So we'll make sure that those resources are available afterwards. So I'll just share my screen. I've got a little bit of a presentation, but it's not too comprehensive. Just tips and tricks. So just obviously CPD in 2023, as Robin said, is very different. That is across the board. We've been working incredibly hard at RACGP to really look at how we simplify it, but also ensure that it is meaningful. And I'd say simplifying and meaningful are two of the big words we're working on, and practically every day to make sure, and taking feedback from GPs to make sure it is suitable for all the different varied scope of practice and type of work that you all do. So just to summarize the changes, and I'm sure you're all aware of them, we are in a 2023 onwards an annual cycle. The college still has a triennium. The real only thing you need to do every 3 years is CPR. Everything else is that annual cycle. There are 3 different activity types. There is educational activities, measuring outcomes, reviewing performance. Again, we've got that 50 hours annually, the CPR, and that annual professional development plan. And obviously it is a changing space now, and there are other CPD homes. So just to give you a tiny bit more information around what those requirements are within the 50 hours against those 3 CPD activity types. Look, I'm going to go through this, but there is much more detailed information on our website and resources. But just a bit of a reminder for you all that there's a minimum of 12.5 hours in educational activities. There needs to be a minimum of 5 hours in both reviewing performance and measuring outcomes to make up a total of 25 hours in that particular type, and then another 12.5 hours to make up the 50. Now, you'll see different logos with the college activities, which Telecare is one of our providers, that shows how many hours in each of those types. And you can see this logo down the bottom. Now, this particular one, for instance, as an example, shows that you can have hours in educational activities, measuring outcomes, or reviewing performance in the same activity. We call these hybrid. So when you look for logos by the college or by any of its accredited CPD providers, you'll see logos that can show one or more of those activity types to look out for. And if you see that logo, that means that we'll be capturing the hours on your behalf, either through our providers, through the RACGP as well. So that's what that logo means, that it's captured on your behalf. Now, we've done lots of work, as I said, trying to work out how do we simplify this to make it, on a page, give you an example of what that might look like. Now, this is a particular example. It's not a true and accurate one. Every single person's could be completely different. But you can see here, and this equals more than 50 hours, but someone might spend an hour doing their PDP, and I'll show you our PDP soon, and it is capped at 5 hours, but you could, it's about how much time you take. You could be doing a mini audit in your practice. It can be a hybrid activity, a mini audit, depending how it's done. And we have templates and resources around all of these types of activities as well. Practice meetings. There is a range of practice activities that you can be using, and your practices can work with us to assist with those as well. So all of those practice meetings can also be reviewing performance. But if you're actually looking at patient data, comparing patient data, making changes based on the data and the review, you could actually also add some measuring outcomes as well. If you've got a speaker coming along who's an orthopedic surgeon, for instance, that didactic part would be education. We've also got online modules in GP learning, for instance, that is our check. We've got reading that you can do that can be captured. You've got case-based discussions and webinars like tonight. So there is lots of ways over a year that can add up to be captured to meet those 50 hours. And this is just one small example of what that could look like. Now, I could tonight spend a lot of time talking, and obviously I actually do run lots of webinars on this particular topic that go for an hour. What I'm going to do tonight is show you some of the ways that you can capture it to make it simple and easy. The first one I'm going to show you, you may be aware it launched this week, our new app. Now, not often I really get to be excited about something, but it is hit number 3 on the charts on iTunes for education. We have put a lot of time and work into this app to make it simple for you. I suggest you all go to the App Store or Google Play, download it, it's free. And our feedback so far has been that it is really simple to do. I'm just going to show you a couple of slides on one slide on what it looks like. You can see your statement there, where it is all the time about how many hours you've done in different parts. You can see your annual requirements. You can search for activities such as if you were looking for an activity, like for instance tonight's, you'd find it there. And you can also quick log activities as well. So if you're doing reading in your practice and you wanted to capture those hours that you spent doing reading or speaking to a different type of specialist and gaining information, corridor conversation around a case, for instance, as well, you could capture it using the app. So that's just one of the brand new things that we've just released. Then what I'm going to do is show you the website, because the website's got a few more details than the app does. And the reason we want to show you this is lots of the practice-based information can be found on the website. Lots of our resources can be, as well as that's where the PDP is. So this is a live website screenshot that I took about 10 minutes ago. You can see on the website really clearly at the top, your total hours so far, how many of the annual requirements you've met, and that RACGP requirement, which is CPR. Now you can see these circles going around will tell you when you've met the minimum requirements in something. So you can see this one is educational 8 out of 12.5 hours. Reviewing performance, measuring outcomes, we've put them together because they are together under the medical board's requirements a little bit as well. Overall, we've met 12 of those 25, but you come down a bit, you can see that reviewing performance is ticked off as completed and 4 out of 5 hours of measuring outcomes. So it's quite clear where everything is there. And as you goes around and captures it, it's there for you. And you can see here there's the professional development plan. This one's completed, but you can actually go and edit it as well. So you can go and reflect and review. It is open now. And you can see here that CPR requirements there, and you can download your CPD statement as well. So that's the front page of the website. Now, the PDP, I've taken a screenshot because I couldn't go through the actual dashboard with you, but really is a sentence or a paragraph about your current situation. Again, it's a sentence or paragraph about your learning goals. It's a reflection on your culturally safe practice that's appropriate to your scope of practice and the practice where you are currently working. There's an annual reflection there as well, and that can be on the previous year, or it could be what you're planning to do now. And then the time you've spent. Now, there's a sample response built into it as well. So if you're not sure what to write, then you can have a look at that sample response. And what I will say as well is there's 2 things. That's capped at 5 hours, but also when we do a quality assurance or an audit, we don't look at your PDP. We report that the PDP has been completed annually, but we don't go in and look at the data in there. That is just for your professional development, just to let you all know that. So that is the PDP. It's quite simple, as you can see, not hard to do. We would love everyone to go in and have a bit of a look and a play at that. Now, you also might want to find education that you are looking to go and see. You might look to find online learning. You might want to find a face-to-face event, things like that. We have updated our browse on our website, and this is also on, obviously, the app, as I told you before. In browse, I've just done a quick search on diabetes. And I have ticked the RACGP-led ones just in this instance. And you can see that here on the side, it's set up a bit like online shopping. And it really is about how to search and find in a really simple way those activities that suit. You can search by the type of activities, the delivery mode, the date, the time, the state, all of those different things. It will clearly tell you how many hours it is, whether it's education and reviewing performance. And all of I think there's over 1,000 activities in there currently, and I think it's the early in March, and that's not bad for the college and all of our providers to have that depth and breadth of activities up there as well. On the next slide, this is the resources section. There is significant amount of resources for you available as well. There is different events like our CPD solutions, which is a summary document. There's lots of guides and templates. And one of the things we're focusing on a lot is practice-based activities. So peer group learning, case-based discussions, and practice meetings. And under this guides and templates, there is lots and lots of templates there for use as well. So they can be uploaded. There's our new curriculum. There's lots of clinical guidelines, our journal, and the library, and lots of other resources in there for you all as well. What I will do is I'll send these two documents here through to Telecare to send the link to you all. There's two main documents in resources for handy tips and tricks. One is the activities for professional development, and the other one is RSCGP solutions. So what we've tried to do is give you hints and tips that are relevant to your scope of practice. So for instance, if you're you specialize in pediatrics or women's health or skin cancer, for instance, there's solutions for those, or it might be based on your scope of practice. So if you're a locum, if you work in rural remote, different things like that, or a metropolitan GP, for instance. So we're really trying to make it really simple for you to suit what you need in your practice. And what I will say also is lots of GPs work for the college. So if you work for the college and do things with the college, nearly all of that will be captured. So if you do exams, if you're a supervisor, if you're writing curriculum, if you're reviewing documents and clinical guidelines and things like that, we'll capture that for you. But also, if you attend other things that are not with the college, then you can capture them yourselves as well in that same capacity. So if you're working with medical students, if you're on other committees that are linked to your scope of practice, you can capture all of those through that quick log as well. And obviously through that significant provider network that we have. And then I said I wasn't going to have many slides because there might be a couple of questions coming through. What we'd love you to be doing now, obviously January to March, is go in and log into your CPD home, download the app, start your PDP, have a bit of a look around and a play. You might find if you've been attending activities such as tonight that you've already started collecting hours. We'd love you to talk to your practice manager as well and your practice team. Are they capturing those things for you? So they're capturing all of the meetings. If you're the lead GP or a principal GP or even a practice owner, you could be capturing on behalf of the other people within your practice. So if you think of all those meetings that you have throughout the year and that's all captured for all of the attendees, then that will certainly start adding up to lots of hours in reviewing performance, education, and even sometimes that measuring outcomes type of activity. We will be obviously sending out lots of communications, but hints and tips really around what new activities there are, if we've simplified anything further for you, because we're doing that a lot. We will be reaching out and touching base as we go. But also when we get to October to December, obviously we'll be reaching out and saying, remember that it's an annual cycle now. So this is annual rather than a triennium, to really help you and support you through that. We'll have lots of webinars, we'll have information sessions. There's lots of recordings on our website as well, if you need any additional information. So that's the general contact email if you want to. I'll send that through to Telecare as well, obviously. But what I might do, Robin, is just stop quickly. We might have 5 minutes, I think, if there's any super quick questions, if we have any. I'll stop sharing. Otherwise, I'm very comfortable to send through any questions to us. We can send through the answers and as we go along.
Thank you very much, Sharon. I hope I'm on screen, but never mind. Yep, that was incredibly impressive. And as I'm just looking myself, I cannot see any questions there at the moment. I think Ray will correct me if I'm...
Yes, that's correct. So
right.
For all our attendees, if you want to ask a question, go to the bottom of your screen. There's a button. There's a box that says Q&A. Click on it and ask questions there. Otherwise, if you want to talk instead, just put up your hand. Put your hand up, and I can unmute you temporarily. But whilst we're waiting for questions, Sharon, I guess my reflections on kind of my own practice is that measuring outcomes is probably the hardest one.
Yep.
Most practice most practitioners. I guess this is all doctors. Would that be correct?
I would say yes, that's overwhelmingly what we're getting. Yep.
Yeah. So I'm having a peer review with my fellow doctors tomorrow, actually, my practice. So I'll be the one being reviewed. So I'll have my measuring outcome points and hours.
That's great. Look, and when we send through information to share, we can add some extra hints and tips on those measuring outcomes for you. And I think our new communication out to members is around measuring outcomes too.
All right.
Excellent.
Here we go. There's one question and then I think I'll go. Would supervising
registrars with weekly teaching count as CPD?
It does. It does. It is
okay.
It is education and reviewing performance, but we'll send you some information on that too.
Excellent. Excellent. As I said, the complexity of that and the details were quite phenomenal. So I've got no hesitation in saying that you're the guru, Sharon. And I hesitate to acknowledge that my college is the College of Medical Administrators. And I fear that they're not as well advanced and not as sophisticated as the College of GPs. So GPs attending tonight can be grateful for the work that your college has done. Not really a question, but the app is very useful and easy to use, is a comment that's come through. And again, repeating that Telecare will forward to attendees the links and the particular documents that Sharon referred to, as well, I think, as the pack of slides, if we can have them.
Absolutely, I can do that for you.
Excellent. Thanks, Sharon.
Thank you so much for having me. We really appreciate it.
Well, thank you very much for that presentation. As I say, the lack of questions probably reflects to some degree the complexity, but I also think that the college has done a brilliant job in making things as simple as they possibly can be in this new era of requirements. Which leads us on then. Thank you, Sharon, and thank you very much. Leads me on then to hand over to Ray, who attendees will already have heard from. Ray is Telecare's Chief Engagement Officer. He's also a practicing GP, and as he's already said, is well involved, very active in this area of CPD compliance. He will moderate the remainder of this session, which includes the 2 clinical presentations. So Ray, over to you. Thank you very much.
Thanks so much, Robin. Thank you. So it's a little bit of a different format in terms of your routine webinars due to the CPD changes. So we're going to do a bit of a performance review or reviewing performance RP kind of session right now. We're going to launch a bit of a poll where we're going to give you a few moments to reflect on a few questions. And then we will introduce Dr. Vivien Li, who's a neurologist who will be speaking to us tonight. But before we launch into that, I want to launch a poll so that we can capture the reviewing performance component of the points, hours, I should say, for the CPD hours tonight. So Nazia, when you're ready, if you could launch the polls so that our attendees can answer the questions, reflect on their current practice, and then this way we can have documented evidence that we can then supply if required for audit purposes in terms of documentation of the reviewing performance CPD hour requirement.
Thank you, Ray. I will just introduce the first question and the rest we can carry on during the presentation. That's okay?
Yep, sure.
Yeah, okay, thank you. No problem. I'll just wait for a couple of more seconds and then we can just launch the results. Good afternoon, Dr. Li. The first question for the migrant actually has been put up. This is just to start with the activity, and we'll just post the results and you can take off. Thank you.
All right, I can see that 84% of participants have participated. So maybe we'll give another 10, 15 seconds. And if no final answers, why don't we kick off? All right, I think 85%. Yes, we got one extra one. All right, well, I'd like to welcome Dr. Vivien Li, who's a my personal friend of mine. So thanks for making the time to speak tonight. Vivien is a specialist neurologist. She completed her Bachelor of Medicine and Surgery at the University of Melbourne in 2011 and received the Australian Medical Association Prize for achieving the highest score in her cohort. She has undertaken advanced training in neurology, including 2 years working at the National Hospital of Neurology and Neurosurgery at Queen Square in London, with subspecialty experience in multiple sclerosis and immunoneurology. Vivien has published in a number of international journals and is currently a PhD candidate at the Florey Institute of Neuroscience and Mental Health, researching multiple sclerosis and neuroimmunology. And Vivien will be talking to us tonight about headaches. Thank you, Dr. Li, for speaking to us tonight.
Thanks very much, Ray. And thank you for inviting me to give this presentation today on headache, which I think is probably quite a common condition encountered by both GPs and also neurologists. So I'll get started. And there are some questions interspersed throughout the presentation as well. So this is the outline of today's presentation. Firstly, I'll speak a little bit about distinguishing between primary and secondary headache disorders. Most of the time I'll focus on migraine, given this is probably the most commonly encountered headache condition in clinical practice, but I'll also talk a little bit about medication overuse headache, as well as cluster headache. And the learning outcomes today will be to describe features of common types of primary headache, understand red flags that could suggest a secondary cause of headache, and also discuss the acute and preventative treatment of migraine. So, as we know, headache is one of the most common symptoms that neurologists are asked to evaluate, and it can be a presentation by itself, i.e. primary headache, or a manifestation of another underlying condition, which is termed secondary headache. So the top 3 causes of primary headache, or classes of primary headache, are tension type headache, which has a global prevalence of around 30% or so in females and 21% in males, and also migraine. Also trigeminal autonomic cephalalgias, which includes cluster headaches, are the 3rd most common type, but there are a number of rarer primary headaches as well. While secondary headaches are quite rare and only account for about 2% of headaches as a whole, they are important to know about, as they account for significantly more of the proportion of cases presenting, especially to tertiary care. And headache phenotypes can overlap or coexist, so it can sometimes make distinguishing between different causes a bit more challenging. So here is a table of just some of the red flags for secondary headaches, and it can be listed under this acronym SNOOP. So talking through some of these features, things that might make you suspect a secondary cause of headache include presence of systemic symptoms such as fevers, sweats, weight loss, or claudication, which could signify an inflammatory, infective, or malignant cause, as well as if there are other risk factors, so someone who is immunosuppressed or already has a past history of cancer, for example. If there are associated neurological symptoms or signs, that could also signify a secondary cause, such as features of increased intracranial pressure or focal neurological symptoms and signs, visual disturbance, etc. The onset is quite important to really tease out, and in particular, thunderclap headache is definitely a red flag. And what do we mean by thunderclap? So it basically refers to an acute escalation from 0 out of 10 in intensity within up to a minute at most, usually within seconds. And the most typical condition we associate with thunderclap headache is subarachnoid hemorrhage, but there are also other causes such as a reversible cerebral vasoconstriction syndrome, venous sinus thrombosis, dissection, etc. And often it can be accompanied by a preceding precipitant such as onset during some sort of exertion. Older age is another red flag, particularly those over age 50, when you might think of giant cell arteritis, or there's potentially increased risk of malignancy as well. There are several Ps to think about: positional, whether it's worsened or improved by standing or lying. It could signify either a low or high intracranial pressure. And prior history we've talked about, but also you want to think about the previous pattern as well of the headache. So someone who has a history of chronic headache, but who develops a new type of headache that is different to their previous pattern should warrant further attention as well. The third P is onset during pregnancy or postpartum. And whilst many women can have pre-existing headaches leading up to their pregnancy, if there's a new onset or a different sort of headache during pregnancy or postpartum, again, that could be associated with their prothrombotic state or something like preeclampsia, for example. We've talked a little bit about precipitants, but also association with Valsalva maneuver, and that could also signify increased intracranial pressure as well, or some sort of mass lesion. So I think there is a question regarding the, so I think we've already answered that one actually. So I think going through those acronym dot points before, so obviously sudden onset, severe, so that's we would classify that as thunderclap headache, which is a red flag. Headache with diplopia could be seen with an intracranial lesion or increased intracranial pressure. Headaches that are exacerbated by coughing, sneezing, etc. So Valsalva maneuvers, again, could be associated with increased intracranial pressure. Headaches with waking in the morning, whilst, that can also be a benign condition. People with sleep apnea, for example, could wake up with a headache in the morning. It could also be one of the positional elements as well. Whereas the last one, we'll talk about it a bit later in terms of migraine features, but this is most commonly seen with the migrainous features, so not so much a red flag for a secondary headache. All right, so moving on. So when we want to exclude a potentially secondary headache disorder, neuroimaging is important to do so. And typically MRI is actually the study of choice for most secondary causes, whilst non-contrast CT has a more limited role. It's mainly useful to exclude hemorrhage acutely in the emergency department, for example. But we've talked about, some of the main causes of secondary headaches, and again, another acronym that you could think about, pressure abnormalities, either low or high, infections or inflammatory conditions, and neoplastic conditions can all be often seen on MRI. If you're suspecting cerebrovascular pathology, such as in many cases of a thunderclap headache, then vascular imaging, either arterial or venous, is important to include as well. All right, so that's mainly what I'll talk about with primary versus secondary headaches, and then we'll move on to mainly focusing on migraine now, which is the most common primary headache disorder presenting to clinicians, both GPs and neurologists, I think. And the most frequent subtypes are migraine without or with aura, and also chronic migraine. So just reviewing some of the diagnostic criteria for this from the International Classification of Headache Disorders. So just drawing out some of these points, firstly, migraine without aura. So by definition, you need at least 5 attacks, but essentially it's talking about a consistent pattern of migraine. rather than something that is new or different. Typically, migraines last between hours to up to several days if it's not treated. And I think we're all quite familiar with typical characteristics. Often it is unilateral, at least during an attack, but it can alternate sides. If it's strictly unilateral and only ever occurs on one side, then that's not so typical for migraine, in fact. It can have a pulsating, throbbing quality and often is moderate to severe in pain in intensity. It is aggravated by sort of movement or physical activity. So people usually want to lie down, close their eyes, not move. And this is one of the distinguishing features actually with cluster headache, which I'll talk about at the end, where people are actually more often agitated, pacing. And we know that it can be associated with some of these features like nausea, vomiting, sensitivity to light, noise, smells, etc. And again, the last point is quite important, that it needs to be better accounted for by another condition. So again, prompting you to think about whether there could be a secondary cause. Regarding migraine with aura, so some of the typical features or aura type symptoms probably most commonly would be visual or sensory, but can involve speech and language, motor, brainstem and retinal features as well. And I guess sometimes these aura type symptoms can be confused or misdiagnosed as, say, a TIA or a stroke. But some of the distinguishing features are that it tends to spread gradually at onset rather than everything occurring all at once. So people might describe, tingling that starts from one part of the body and then gradually migrates over minutes to involve the whole arm, for example. And typically aura symptoms are positive rather than negative. So positive means, tingling, pins and needles, for example, rather than loss or lack of sensation. Or in terms of visual aura, people might describe scintillating scotoma rather than lack of vision, or what you might associate as amaurosis fugax, where there's a curtain coming down type phenomenon. So there are some of the features that would help distinguish between a vascular event such as a TIA or a stroke versus a migraine aura. And then in terms of chronic migraine, this is mostly defined by its chronicity and frequency, I suppose. And this is, again, important when you come to consider some of the PBS criteria for some of the migraine treatments. But essentially, people need to have at least 15 headache days per month for over 3 months. And at least on 8 days per month, they need to have some of these migraine type features. So whilst the diagnostic criteria do talk about quite a lot of the clinical features already, it's sometimes also useful to think about different phases of a migraine, as people might present or describe different features, which when put together can make you diagnose migraine. So generally we think about 5 different phases, in fact, starting from prodrome to aura, headache, postdrome, and interictal. And they may potentially overlap or might not always occur every single attack within an individual, but are useful to get through the history. So what we talk about with prodrome actually is quite common, and people can describe things like yawning, polyuria, mood changes, irritability, before any aura or headache symptoms emerge. And food cravings is an interesting one, as people think about various food triggers for their headaches or their migraines, but in fact, it might actually be part of the prodrome and is just associated with sort of temporally with beginning before their headache starts. And then aura, we've talked about with potentially involving different manifestations, and can occur or overlap or even occur without the headache itself. And then the headache, we've talked about its clinical features being often unilateral, severe, throbbing, aggravated by movement, etc. And then post-stroke, whilst the headache might actually resolve, many people still describe feeling not quite right, just more fatigued, difficulty concentrating, etc. During the interictal phase, most people are generally relatively symptom-free, but they can still have some lingering kind of hypersensitivity type symptoms, including to light, noise, movement, just a sense of disequilibrium, for example, as well. So moving on to management now, why do we need to manage migraine? Well, firstly, they can be quite disabling, and a lot of people with migraine report significant functional impairment, including having to miss work or school and daily life activities. And also, if it remains untreated, people may start to rely more on acute treatments and become a predisposing factor to evolve into chronic migraine. So starting with some general lifestyle type advice, this is all fairly self-explanatory, I guess, but just essentially having a good lifestyle with regularity and routine is important. So sleep, meals, hydration, exercise, probably what we all need to follow, but also trying to incorporate things like relaxation techniques can be helpful as well. Obviously, if there are some known triggers, then trying to avoid those is very important. So moving on to acute treatments, so basically treating an acute attack, and these can be broken down into non-pharmacological as well as non-specific or migraine-specific therapies. So people might already know to use a cold or heat pack, rest in a dark, quiet room, sleep it off. In terms of non-specific treatments, so these include high-dose aspirin, non-steroidal anti-inflammatories, paracetamol, and for nausea, things like metoclopramide or prochlorperazine, and they can be used in combination as well. Moving on to the more migraine-specific treatments, so we've got several medications under the triptan category, which is a 5-HT1 agonist, and they come in different formulations from oral, nasal, subcut injection for sumatriptan. Wafer is rizatriptan and comes in a wafer, and then the other ones are oral therapies. And they do differ slightly in terms of their pharmacological properties, with naratriptan in particular having a longer half-life. So it's best to counsel people to take them as early as possible after they start feeling the migraine coming on, and they can repeat the dosage after 2 or up to 4 hours for naratriptan within a 24-hour period. We generally say contraindicated if there's a significant history of cardio or cerebrovascular disease, given the possibility of vasoconstriction, and not absolutely contraindicated, but just to caution if they're already on another serotonergic medication. And as I mentioned before, these can be used in combination with the non-specific treatments. Things to avoid, however, are opioids, including codeine and tramadol, and also things like oxycodone, etc. And also excessive use of acute treatments to avoid leading to medication overuse headache. So these are some of the guidance in terms of number of days per month to try and limit the use of triptans too. There was a question in the Q&A about not taking triptans too early due to rebound headache risk. So I guess rebound headache is kind of a somewhat synonym for medication overuse headache, I suppose. But we still would counsel in acute treatments, for acute therapy at least, to try and take the triptan earlier rather than later before the migraine escalates for it to be most effective. You don't want to be using it too frequently, however, which is what may compound the risk of rebound or medication overuse headache in the longer term. And I guess that will lead on to the discussion about preventative treatments, how to avoid overuse of some of these acute treatments as well. So I guess when do we consider preventative treatments? So there's no sort of hard and fast rule, but typically if people are having 2 very severe or disabling or 4 less disabling migraine attacks per month, and they're starting to increase their acute treatment use, then you want to think about preventative treatments. Or if they already have features of a medication overuse headache, then you want to try and gradually reduce their reliance on acute treatments. And as you probably all know, there's a whole range of different oral medications that could be preventative treatments. And the choice often depends on their side effects, patients' comorbidities, and I guess what you feel comfortable and used to using as well. But the general principles are to start low and gradually increase to the maximal tolerated dose, because often people can unfortunately experience side effects, and then to trial for at least 8 to 12 weeks to assess its efficacy. Often we see people who just take the lowest dose for a few weeks, don't feel it's effective, and then stop. And it's hard to know whether that was just because the patient didn't get to the maximum tolerated dose to know whether it was effective or not. And it's important to sort of discuss the goals as well. And typically the good response is considered to be at least a 50% reduction in headache frequency. And it's useful to have a headache diary. And there's lots of different phone apps and things. This is just one example that was taken from the Headache Australia website, where there's different symbols for, when the headache occurred, how long it took, potentially if they're having their period, if they took acute medications or not, but just having some sort of objective record before starting preventative treatment is useful to know whether it's actually working or not. But this is just taken from therapeutic guidelines about some of the potential comorbidities and drugs that could be considered, or drugs to potentially avoid. So, for example, weight gain is often a common concern, and things like sodium valproate, bisoprolol tend to aggravate that, whereas things like candesartan and topiramate are a bit more weight neutral or even promote weight loss potentially. So these are just some of the common preventative treatments in terms of their initial dose and increment dose and target dose, and some of the side effects and contraindications. So probably in my practice, the most commonly used ones I would prescribe would be amitriptyline or nortriptyline, topiramate or propranolol, again, depending on some of their previous history or comorbidities / contraindications as well. But obviously, just some things to highlight are that valproate is contraindicated in women of childbearing age, obviously due to teratogenicity. And unfortunately, some of them are associated with sedation, which is important to warn people about, but also can be a useful side effect if people are having difficulty with sleep, for example, as something to help promote sleep at night time. I thought I might just include a case as well. Sorry, it's a little bit wordy, but so this is a 27-year-old woman who's presented for treatment of migraine. She's having headaches that meet the criteria for migraine with and without aura 6 or 10, so sounds like a pretty recurring pattern of it. However, they have been increasing in frequency over the past couple of years and now occurring 10 days per month. She has tried rizatriptan, but that's become less effective as time has gone on. It's affecting her work. Not really much of medical history, just reflux, blood pressure and pulse adequate, neurological inflammation normal. She's been concerned about the risks and side effects of preventative medication, including weight gain, and also heard that topiramate made a friend feel like a zombie. And she's heard that new treatments for migraine were available and wondered if she might be eligible. So I guess some of the pointers are just that to firstly confirm the diagnosis of migraine, which sounds like it is the case. I think in her case, given the frequency, severity and impact of the migraine, you would consider certainly starting preventative treatment in herself. You want to explore what their particular concerns are regarding starting preventative treatment, in her case being weight or cognitive side effects, and discuss potential options in this case. I mean, some of these, the options going back to the previous table, that are less likely to cause weight gain. I mean, topiramate we talked about, but it can potentially be associated with cognitive side effects. So something perhaps like propranolol, candesartan might be appropriate. We don't want to use valproate because she's a young woman. Venlafaxine could also be another consideration as well, but sometimes can have some cognitive symptoms associated with it also. In terms of these newer treatments, so well, I'll talk about that a little bit later as well, but she potentially is referring to the CGRP antagonists. But at this stage, if she hasn't tried any other preventative treatment, then she wouldn't actually be eligible for that. Just another question in the Q&A. Migraine attacks could be associated with hypertension, with triptans being contraindicated. Typically, if someone is just has hypertension alone, then it's not necessarily a contraindication to using triptans. It's more if there's quite severe or established cardiovascular or cerebrovascular disease that you would need to be more cautious. So moving on to other preventative treatments then, and these are some of the more, I guess, advanced treatments, namely Botox treatment, injections, and also the CGRP antagonists. So Botox, essentially, it's one of the treatments that's indicated for chronic migraine, and sorry, it's a little bit small, but it's indicated on the PDS for chronic migraine. So going back to the criteria I mentioned before, they need to have at least 15 or more headache days per month, 8 of which are migraine in nature. And to qualify, you need to have had at least trials of 3 of the oral preventative treatments and either been intolerant or had no inadequate response. And then to maintain Botox treatment, people need to have at least a greater than 50% improvement after 2 treatment cycles. So whilst in the, so the standard protocol is injection at 31 different sites across the scalp every 12 weeks. And clinical trials only really showed a modest benefit compared to placebo itself. But in actual practice, I think there is certainly a much greater benefit than it seems to be indicated by the trials. But it can take a few weeks to experience improvement in pain relief. And some people do report wearing off of the benefit towards the end of that 12-week period. It does generally seem to be fairly well tolerated and fairly safe in terms of the procedure itself, but it does need to be avoided in people who have a history of neuromuscular junction disorders or other head or neck issues. Generally, we do also avoid it in pregnancy, although there's no actual definite evidence of significant harm, but generally we steer away from Botox during pregnancy. Now, regarding the CGRP antagonists, which have become available in the last couple of years. So I think increasingly patients are becoming aware of these and asking about these as well. So calcitonin gene-related peptide, it's a neuropeptide that's found throughout the nervous system, thought to be involved in migraine pathogenesis. And we've got different monoclonal antibodies either against CGRP or the receptor itself. And again, it's been found to be effective for both episodic and chronic migraine. And the 50% responder rates were 50 to 60% in the treatment group. So over half of people had more than a 50% reduction. But it seems, again, the real world efficacy may be actually greater than this. What are the advantages? I'd say probably the best benefit is that it's better tolerated compared to many of the oral treatments, which have a number of different side effects, but also potentially faster onset of action because you don't have to titrate up the dose and few interactions as well. The most common side effects are just injection site reactions, very rarely hypersensitivity, constipation, and hypertension associated with one of the monoclonal antibodies. And again, we don't have enough data at this stage for pregnancy or breastfeeding, so they're generally avoided. Again, just quickly, the indications for initial treatment are pretty much the same as the Botox criteria. And to keep going with it, you need to have had at least a 50% or greater reduction. So again, another helpful use of the headache diary to document this. So the treatments that we have available at the moment are the two subcutaneous injections, fremonezumab and galcanezumab, which are injected monthly, although fremonezumab can be actually given every 3 months, but at triple the dose. So 3 injections lasting for 3 months, basically. Sometimes people might prefer it if they're, for example, traveling or just lifestyle reasons. The other two, one is an IV infusion, and then erenumab is against the receptor, whereas the other 3 are antagonists against the ligand. So I think just moving on to some of the other, I guess, more complementary therapies that people might come across to assist with preventative treatment. So there is a bit of evidence for things like magnesium and riboflavin. These are, I guess, more, someone who's pregnant, for example, might want to try these because they're non-medication as such. And then things like CBT, relaxation, meditation techniques can be helpful complementary therapies. There is some evidence for acupuncture as well, demonstrated in this Cochrane review, with about 40% of participants having an over 50% reduction of frequency compared to the sham arms. And you might hear about this external stimulation device called Kefali, which is, I guess, like almost a TENS machine that people can place on their forehead, either as an acute treatment or daily sessions to help with preventative treatment as well. So, sorry, I think if we bring up question 2. I don't know if I can see what the result is actually.
Oh, yes. People are still answering, Viv. So there's about 80% of participants have answered. I might give maybe another 15 seconds and then we'll end the poll. Can you see the results there, Viv?
Yes, yeah. Yeah, so yeah, chlorpromazine is not a preventative treatment. So the others I think I've talked about in the various slides, but chlorpromazine can sometimes be used IV as an acute treatment, for example, when people are presenting to the emergency department, that wouldn't be counted as a preventative treatment. All right, so moving on to medication overuse headache, which I guess is somewhat linked to chronic migraine and commonly overlaps. So typically this is, we think about it when people are frequently using acute treatments. So in particular, the triptans, opioids, or other combination analgesics. So things like Panadine, Panadine Forte, etc., for over 10 days per month. or otherwise paracetamol or NSAIDs alone for over 15 days a month. And it can be a tricky symptom to treat when it's entrenched and people are sort of reliant on using these acute treatments. Often it can be associated with other comorbidities as well, so sleep disorders or mood disorders, and it's important to try and address those as well. So the main, I guess, management strategies is to try and, over time, wean down the frequency of use of these acute treatments whilst instituting another sort of preventative treatment to reduce the overall frequency and severity of the migraine attacks, and also treating the other comorbidities as well. So just another brief case on this. So this is a 54-year-old man again, who's now having daily headaches, but with migraine starting in his early 20s and have increased in frequency over the last 9 years. So it's already, he's already tried many different preventatives as listed there without significant benefit. And over the previous year has been using over-the-counter analgesics 2 or 3 times a day. So definitely meeting that, I guess, frequency criteria. They tend to resolve just for a few hours, but always recur. So sort of a rebound type phenomenon there. There's also a number of other features like stress, poor sleep and snoring. He's irritable. His mood is being affected. And there's not really any red flag features. His neuro exam is normal and had a normal MRI a few years earlier. So I guess some of the points to discuss are just, firstly, the diagnosis of chronic migraine and medication overuse headaches. So he seems to be having daily headaches, so that meets the chronic migraine sort of frequency criteria and is overusing acute treatments. So in terms of preventative medications, I mean, I guess there's different pros and cons for various options, but you might want to consider something like venlafaxine, which could have benefits in terms of mood as well, or something like candesartan if he's got a history of high blood pressure as well, which could be associated with something like sleep apnea. And then over time, you want to try and reduce the use of the acute analgesics and, as I mentioned before, addressing the other comorbidities and lifestyle changes. I think the question 3 as well, if we can. Just recapping the medication overuse headache diagnosis.
So the poll's been launched and we're getting some responses coming in. Give another 20 seconds. We've got about a third of respondents, participants having responded. Still a few more trickling in, so I might give it another 15 seconds. Final answers. There we are. Those are the results.
All right, great. Yeah. So I think everyone, most people have chosen the correct answer. So yeah, typically triptans or combination treatments, opioids for 10 days or more, or Panadol for 15 days or more. And also if they're on long-standing opioids as well, that would also be considered medication overuse. Even if it's for another indication, it could compound medication overuse headache. Whereas if they're only using something like ibuprofen a couple of times or 4 or 5 times per month, that's still considered okay. So I think just going back to some of the Q&As, blurred vision before onset of headache, does that count as aura? So this is pretty common, I guess, that people describe this. I mean, it's a bit of a fine line as to whether you'd strictly count that as an aura. The most typical visual symptoms would be sort of something that's positive, like the scintillating scotomas that I mentioned, things like flashing lines or waves in the corner of the vision that can migrate throughout the visual field. Whereas if it's just blurred vision, whilst it can be a common symptom associated with a headache, I probably wouldn't count that as a definite visual aura. Medicinal cannabis. So I think there's probably a lack of high quality evidence for cannabis in terms of migraine treatments. I think there are some small studies that suggest it can reduce pain and things like nausea and so forth, but definitely wouldn't be sort of my first line recommendation. And given that, particularly with availability of things like CGRP antagonists now and Botox, which are generally very effective, it's probably not something that I would normally discuss with the patient as an option. And then migraine related to the oral contraceptive pill. So I did have a couple of, maybe it's in the next one, regarding sort of headache in women. I haven't talked specifically about the contraceptive pill here, but I think there's lots of different associations between hormonal treatments and migraine, and it can be different for different people as well. So some people might feel better on oral contraceptives versus some people having exacerbations in their migraines. It can also depend on the sort of estrogen component as well. I guess one thing also to be cautious of is the potential association with estrogen-containing pills and stroke, and in people with migraine with aura, particularly in smokers as well. Whilst the absolute prevalence is still very low, typically in people who are of a younger age group, that is still something to consider, and you might need to consider an alternative contraceptive if that is the case. Osteo or chiro treatment, I think, again, there's probably limited sort of high quality evidence, but certainly people can get benefit from physical therapies, massage, osteo, chiro, etc. I think it is just a little bit dependent on the individual and what they want to try, but can be certainly complementary to the other medications as well. As part of PMS. So maybe I'll cover this briefly in menstrual related migraine. So there are people who have quite strongly associated migraines in their menstrual periods, and it's thought to be associated with sort of a drop in estrogen in the late luteal phase and early follicular phase. So kind of starting a couple of days before to the first 3 days of their menstrual cycle. And when the cycles are predictable, it can be helpful to institute what we call a mini prophylaxis treatment. So treating with medications around that perimenstrual period for 5 to 7 days or so. And the options include a non-steroidal anti-inflammatory, particularly if they've got other menstrual type symptoms, but also long-acting triptans. So, for example, narrotriptan, 2.5 milligrams daily to BD, just for those 5 to 7 days can be quite helpful, particularly if their cycles are predictable. In terms of pregnancy, so people's experience can vary. Some people find it improves, some people can find it worsens, but I think most people with my pre-existing migraine experience improvement during sort of the 2nd and 3rd trimesters when hormone levels become a bit more stable. But as I mentioned before, you do need to be cautious about something that's new or different, particularly associated with the prothrombotic state. In terms of what is safe or safer to use, so acutely, the main safest options are paracetamol and metoclopramide. NSAIDs potentially, but before 30 weeks gestation. And then in terms of preventative treatments, so I mentioned before the sort of supplements like magnesium and riboflavin are generally considered safe. And then in terms of pharmacological treatments, so I'd caution people that, nothing is 100% safe, but the safer options might include pazotifen, amitriptyline, and propranolol if someone really needs a medication option. You can also consider things like nerve blocks, like a greater occipital nerve block, or neuromodulation, like I mentioned, the Kefali device as well. That's the trigeminal nerve stimulation. And again, just to mention that sodium valproate is contraindicated, along with topiramate as well. I've just put up a table that includes some of the other kind of secondary headaches during pregnancy that could be of concern. So I won't go through it here, but mostly they cover sort of the prothrombotic states or preeclampsia and pituitary apoplexy as well. Prednisolone can be considered in pregnancy. Generally, prednisolone is considered relatively safe. So finally, just to talk briefly about the trigeminal autonomic cephalalgias. I think we're close to running out of time, but this is another class of primary headaches, of which cluster headache is the most prominent syndrome under this, but it also includes these other conditions as well: paroxysmal hemicrania, hemicrania continua. And I guess what unifies them is that they involve usually quite intense pain and also autonomic symptoms in the trigeminal distribution, most typically in V1. And that distinguishes it from trigeminal neuralgia, for example, which is usually in V2 or V3. And the autonomic features that are associated include ptosis, meiosis, tearing, rhinorrhea, flushing, oral soreness. And I should mention this is almost universally unilateral, with the autonomic features being ipsilateral to the side of the pain. So cluster headache is the predominant condition under this group and more typically affects males than females. And the typical clinical features are listed here under the acronym SEER. So side-locked, so always typically occurring on one side. And whilst I said migraine can be unilateral, it's not strictly unilateral all the time. Often the pain is excruciating, more severe than migraine. And in contrast, again, it's associated with agitation, whereas in migraine, people want to lie still and eliminate all external stimuli. And there is this periodicity or regularity that can coincide with different times of the year or certain times of the day during the bout. And the typical pattern is that they have episodes of attacks with an intervening remission period, but it can become chronic as well. So there's three categories of treatment. So acutely during an attack, the most effective treatments are fast-acting triptan, i.e. sumatriptan, probably best given subcutaneously, but can be given intranasally. And also high-flow oxygen, that's 100% given through a non-rebreather mask for about 15 to 20 minutes. When people are in an acute episode that need to also transition to some sort of preventative drug that can't have the acute treatment all the time, there is a transitional or bridging phase where you can use high-dose prednisolone, gradually stepping down over a couple of weeks or so. And then preventative treatment is most useful for chronic cluster headache, or it can be used intermittently during the cluster, an episode rather. And the most common treatment is verapamil, which is gradually up titrated, up to as you can tolerate, but just need to do an ECG before commencing with dose increases. Some of the other options I've listed there, including things like topiramate, lithium, melatonin, etc., but the evidence is a bit less strong for their effectiveness. So shall we bring up question 4 quickly?
Yep, so we've got the poll going and people are putting in their answers now. So we'll give it about a minute.
I think I only have 1 or 2 more slides after this.
All right, I'll end the poll soon. Last final options. Okay, 10 seconds. All right.
Yeah, so that's right. So the first 2 and the last 2 options are treatments, either acute, bridging, or prophylaxis for headache, cluster headache, whereas if it's just 6 litres per minute via Hudson mask, then that amount of oxygen is generally considered insufficient for acute treatment. All right, so just quickly, whilst I've mainly talked about cluster headache, there are these other 3 conditions which also fall under trigeminal autonomic cephalalgias. And they're sort of differentiated in terms of their time course and also indomethacin responsiveness as well, typically for paroxysmal hemicrania and hemicrania continua. Their indomethacin, response to indomethacin is almost a sort of diagnostic tool in a way. And I think just lastly when we actually diagnosing cluster headache, neuroimaging is generally recommended to exclude secondary causes, some of which are listed there. I've mentioned previously already things like arterial dissection, other vascular conditions, and pituitary conditions can also sometimes be a mimic for cluster headache, but also, to consider non-vascular conditions, even like acute inguinal closure glaucoma, pituitary conditions, which typically can be picked up on imaging. I think this is the last question, and then I've just got a summary slide at the end. So again, just going back to thinking about secondary causes.
So answers coming in, about half have answered. Give it another 15 seconds.
Yeah, so basically all of the above is correct. Don't think I need to comment too much more on that. All right, so in summary, most common primary headaches, attention type headache, migraine, and trigeminal autonomic cephalalgias, of which cluster headache comprises the majority of cases. And just going back to the acronym for secondary headache red flags, so systemic symptoms are the neurological signs, a very acute thunderclap onset in older age, and then the various Ps. As I talked about, migraine has some of these clinical features, but can encompass other symptoms beyond just the headache itself, thinking back to those 5 different phases. And it's important to adequately treat migraine to reduce comorbidities and also avoiding transition to chronic migraine or medication overuse headache. And lastly, we talked about cluster headache, which is much less common than migraine, but there are some distinguishing features that are listed there as well. So I think that is the end. Happy to, don't know if there's any other questions at this stage.
Thanks, Dr. Li. So I'll open to see if anyone else wants to ask any questions through the Q&A function. But otherwise, we will be shortly launching a link and a QR code for everyone to scan to really submit their reviewing performance questions and answers again, so that we can document the CPD hours for everyone. So any final questions before we have a little bit of a break for reflection before we move on to the next talk? All right. I'm not seeing any Q&A questions. So thanks, Vivien. Thank you so much, Dr. Li, for talking to us tonight about a topic that we see in practice a lot every day. Dr. Nasir is going to launch a QR code. So if all of you can please scan that QR code and answer the questions and also the reflection questions around what you will do to change your practice. That will be very helpful for us to help you document your reviewing performance hours, so that there is evidence. If you ever get audited, there will be evidence that you've done the reflection. So if you scan the QR code, and I'm going to put into the chat the actual link as well, if you want. So it's using a secure form called Snap Form. This is all confidential. We're not going to share your answers with anyone else, but it is helpful for us to know who's answered and who we will kind of upload the review and performance hours for. So for those who can't see the QR code, if you just look into the under the chat box, I've put that in there, and I'm just going to type it into the Q&A box as well. So under answered Q&A questions. But if you look at the chat box, you will see the direct link to the secure form. We're going to give about 15 minutes, so we'll return at 7:35 to give you a chance to grab a drink of water, but also to answer those questions and reflect on how you will change your practice in the context of what we've learned tonight from Dr. Vivien Li about headaches. All right, thanks all, and I'll see you in about 15 minutes. Hi, everyone. We're just about to launch into the second session of the night. For those who couldn't hear the audio, it was because we were just giving a 10-15 minute break for everyone to complete the reflection questions so we can document the reviewing performance CPD hours. So hopefully everyone's had a chance to use the QR code, use the link that I posted in chat and in Q&A. So hopefully plenty of you have completed the questionnaire that will form part of our evidence for documenting reviewing performance submissions. And I've heard a lot of emails coming into my inbox that's notifying me of the form submissions. I know that plenty of you have submitted that. So thank you very much so that we can document the reviewing performance hours for everyone. Okay, so next up, we've got Dr. Clinton Colaco, who's joined us tonight to talk about infections in a return traveller. Dr. Clinton Colaco is an infectious disease physician with additional training in general and acute medicine. Dr. Colaco completed his MBBS at Bond University, followed by a Masters of Medicine at the University of Sydney. He completed physician training across Western and Southwestern Sydney hospitals. So thank you very much, Clinton, for talking to us tonight. I'll hand over the floor to you and I'll go off video now. Thank you very much.
Thank you, Dr. Wen. Dr. Nasir, are you able to share my slides?
Yes, Dr. Colaco, just give me 1 minute. I can share
Yeah.
that.
Cool. Okay.
Is it visible yet?
No, it's not in presentation mode.
Okay, 1 minute. Sorry about the delay. Can we keep it like this? Is that all right?
So Nazia, if you press the bottom right corner, there's a near the 88%, and then next to that on the left, there's a presentation symbol. Or from beginning, you can do top left corner under file from beginning.
This one?
Can you go to display settings and then change it to yeah,
that looks perfect. Okay, great. Okay, thanks for that. So yeah, my name's Clinton. I'm an infectious disease physician, and the topic I'll be discussing today is infections in the return traveller. And this is by no means an absolutely comprehensive talk on infections in the return traveller. It's probably more catered towards general practitioners and what you guys might see in a general practice setting. However, I will talk about some of the other stuff that we sort of see in a hospital-based setting at the very end. Next slide, please. Next slide, please. Yeah. Okay. So learning outcomes. So the three main things that we're going to discuss today are determining a systematic approach to assessing a febrile return traveller, discussing travel-associated diarrhea, and common presentations in febrile return travellers. Next slide. So there are a few ways to approach a febrile return traveller, and so the first way to look at things is through risk factors and things that we might ascertain from their travel. So their destination, and so whether they've gone to Asia or Africa or other countries, their duration of travel, this really affects things like the incubation period and what kind of infections they might have had, and where we should spend some more time in terms of asking specific questions about specific travel-related activities. Reasons for travel, generally speaking, a lot of people are traveling to visit friends and relatives, particularly in the subcontinent, and this can have a bit of an effect in terms of what we might find in terms of infections, whether they might relate to animal exposure or exposures on a rural premises, for example, or if it's for business reasons and they've actually just stayed in the city. Season is another thing to consider. So wet season, lots of rain, maybe mosquito bites versus lots of sunshine. Maybe they've gone hiking or somewhere in North America and been bitten by ticks, for example. The type of travel, so backpacking versus staying in a nice fancy hotel, and rural versus urban. Behaviors, and I will just draw your attention to the photos on the right, and they're meant to suggest different things that people may do. So the first photo is reflective of someone potentially eating street food in a subcontinent related country. The second picture would be swimming in open waters, and the third would be caving, which probably a lot of people don't do, but that can lead to some very interesting infections like histoplasma and potentially bat-related infections as well. Specific prophylactic measures, including malaria, chemoprophylaxis, and individual host susceptibility is something else to consider as well. Next slide, please. So it's important to assess severity and look for localizing symptoms or signs. And so these might actually give us a pretty good clue into specific diseases together with their history. So malaria, if they've visited a particularly endemic country, such as in Africa, and we can do very specific tests for malaria, such as an ICT, a thick and thin films, and in certain situations, a malaria PCR, particularly if it's early on in their course. If you're suspecting typhoid, particularly if you think someone's visited northern India and the Punjab region of Pakistan, or India for that matter, it's quite important to do basic things like blood cultures, stool cultures, and this might lead to a very prompt diagnosis. And bites due to arboviruses, so dengue is the main one we consider here, and you can do dengue serology, for example, as well as what's encompassed in it is an NS1 antigen, and this can sort of tell you if they are positive for dengue or another arbovirus that might cross-react. Or you could do some other things like rickettsial serology for rickettsial-associated infections if they might suggest they have had a bite previously. And most febrile return travelers should be hospitalized, and they do present to hospital quite often. However, from my experience, at least in a typhoid setting where I do a lot of research on this, a lot of patients have started in primary care, had pathology taken as an outpatient, then referred into hospital, and then later contacted by public health to say a blood culture has returned a positive result. And specific diseases, 90% of tropical fevers are just basically due to one of these three listed infections. So it's important to recognize the early signs and what you can do to test pretty promptly. Next slide. So another way to look at infections is based on fevers and their time periods. So if basically less than 10 days, it really limits you to a few different things that are quite common, like dengue and influenza being by far the most common cause of fever, particularly when they've visited a country in wintertime. A little bit of shout out to influenza A, which I had a few months, well, 1 month ago when I was in India, in the southern part where it was about 35 degrees. So even hot temperatures doesn't really prevent that from happening. The spread is still quite common in wintertime, and we still have endemic influenza A and B in Australia with a case rate of about 2%, which I'll talk about later. Some things that we don't see very much of here, like plague, but it does exist out there, and we do see lots of Legionella going around. So travel doesn't necessarily need to be overseas. It could be within Australia as well. Other things in terms of a 3-week incubation, so malaria, and there's different types of malaria that can come back at later stages. Viral hemorrhagic fever, I think the scope of this talk is a bit more narrow, so I won't touch on this too much, but a bit at the very end. Q fever, particularly with animal exposures, and then it really depends on which countries they've gone to and what their exposures are. So if they're shooting pigs for fun in rural properties, and some pigs have had aborted fetuses, then you might suspect something like brucella, and yeah, bites and things of leptospirosis. And then greater than 21 days, like I mentioned, malaria, things like HIV can always present with a seroconversion illness, which is basically flu-like symptoms. And then there's the weird and wonderful in terms of tuberculosis, liver abscesses, and lots of other things. Yeah, next slide, please. So incubation periods, some more specific ones in terms of like the arboviruses, you can see that they're much lower. They're found in the tropics. You can get things that cause encephalitis, particularly arboviruses. We've seen a lot of Japanese encephalitis about 11 to 12 months ago, and now there's a bit of a resurgence with a couple of cases noted in the last few weeks. We've seen a lot of enteric fever, particularly over the Christmas, New Year period with returned travelers. We always see the odd HIV. I think in my district in Western Sydney, we see one every few months, maybe even more than that when you add the outpatient clinic. So it's always there. And there's a few other infections there, as you can see as well. Next slide, please. Yep. So then going on to a bit longer, so you've got things like hepatitis A, which can be acquired from overseas. A lot of people, if they do get vaccinated against typhoid, would get a Hep A vaccine as well. Hep B is something to also consider. And then again, there's a lot of weird and wonderful depending on the exposures that the patient might have undertaken. Next slide. So the other way to look at things is a syndromic approach, and that's like fever plus a rash would be one instance, and so dengue can present with a fever as well as a lot of these other conditions, as well as things like meningococcus, syphilis, where you get maculopapular rash in the hands. So there's a lot of different fever rash type syndromes. You can get fever with diarrhea. I've talked a lot about typhoid and paratyphoid, but you can get other things like Shigella and Campylobacter and E. coli and other things that are much more common as well. And yeah, don't forget the respiratory viruses. There's a lot of COVID going around, but there's tons of influenza, common colds, lots of rhinovirus, human metapneumovirus and enterovirus that can cause all sorts of things. Tuberculosis is not something that you would see in the very acute period, but it's something to consider if they've come from overseas or emigrated from overseas, or they spent long periods of time or gone back and forth and may have been exposed to TB or been hospitalized at some point in time. And then again, there's the weird and wonderful in terms of worms and other parasitic-like infections as well. Next slide, please. So fever plus neurological symptoms. So we do see the odd cerebral malaria in hospital, which can be terrible. We do see the odd meningococcal and tuberculous meningitis, but we don't really see a lot else unless you suspect other things through blood tests that could be off, like eosinophilia might lead you down the garden path of looking for some of these parasites, but other than that, it's pretty rare to see some of these. Encephalitis, I've mentioned Japanese encephalitis, but there's a lot of other encephalitides that can cause viruses that can cause encephalitis, and that's something to consider. And never forget things like syphilis, which could be easily tested and reveal some of a quick result. And then the other way to look at things is fever plus jaundice. So the hepatitis, malaria, yellow fever, liver abscesses, and things like Q fever and so forth. Next slide, thanks. Fever and lymphadenopathy. So we've got rickettsial infections, tuberculosis. Again, you can get a lot of lymph nodes, cervical lymph node involvements. But TB can really affect anywhere where there's a lymph node. Syphilis, and yeah, we don't really see tularemia. Possum disease hasn't been seen in years, and I don't think I've heard of much of African trypanosomiasis either here. Next slide. So again, where they're going, I might tell you a little bit about what could be going on. So like we don't see much Zika here, but there always is the odd question that comes up about it. There's other things to consider, like chikungunya, particularly in Southeast Asia. There was a couple of cases, I believe, in Western Sydney in the last year or so. But yeah, a lot of malaria around it. So that would probably be something to consider, particularly when they've gone to Africa. Next slide. Now, this is a really busy slide, but essentially it really covers all sorts of exposures. It's pretty hard to find things that are not on this list and what they might cause. Just some interesting things to note. Medical tourism is growing day by day, year on year, and is probably only going to get bigger with more flights and people traveling as a result of COVID. And I know a case recently where we had a patient, or I wasn't looking after this patient, but I heard of a patient that had liposuction from an Indian private hospital, then it was admitted for necrotizing fasciitis, secondary to really ESBL, E. coli, and we've seen lots of mycobacterial infections like Mycobacterium abscessus, particularly in breast implants. And then the other thing that's something to consider is colonization when they've been hospitalized overseas. So we see a lot of carbapenemase producing in organisms as well. So there's a lot with medical tourism that might lead you down a certain path, and that's really when you involve an infectious disease physician as well. Another thing to consider is their work or occupation. I remember when I was a final year student, it was 2015, and it was about the Ebola outbreak going on, and we had a guy come in that was in Mali in West Africa, and he was playing with rats, and then he was a query Ebola when he came to Australia with terrible symptoms, terrible rash, fevers up to 40, and we thought maybe he had Lassa fever, so or some sort of other viral hemorrhagic fever. So there's lots of other things to consider, particularly if you delve into their workplace, if things don't really make sense. And then other recreational activities to consider, things like hiking, swimming, ocean exposure, particularly for mycobacterial infections, hot tubs, caving, as I alluded to, and yeah, other adventurous things. So history is really important for a lot of this, as well as their animals. And I'm not very experienced with pre-travel vaccinations, not something that I routinely do, but these are some of the things that you guys might be a bit more involved in, and these are very easy to promote, particularly when they come in batches. So Hep A and typhoid come together. So it'd be very important to counsel your patients before they go overseas, or maybe just ask them about their travel plans. As I mentioned, I do a lot of work with typhoid, and a lot of people either don't know about it or just think that they might have left their subcontinental country many years ago and it would be the same as returning and eating the street food. So it's important to remember that they don't have that kind of immunity once they've left and spent a long time in Australia. And then a lot of these other things that we may not have seen before we are. So as I mentioned, Japanese encephalitis, you can be vaccinated against for. Influenza, we should be starting to get our vaccines very soon. So it'd be important to take that when it comes out. you can get hepatitis A vaccine as mentioned, and then everyone should have had their routine childhood vaccines. However, there's a few that slip through the cracks, so that's something to look at as well. Yeah, next slide. Yeah, so other things to consider if they're immunosuppressed, and this is an area where you might want to get help maybe from an immunologist or ourselves if they are someone with an infectious sort of disease. If they have HIV, this is something that we would probably be taking care of anyway. But there's a lot of patients on biological agents, and sometimes this is covered by their specialist if they're under a rheumatologist or a gastroenterologist, but other times I believe you guys might be looking after this. It'd also be important to consider inactivated vaccines where they may not actually make a protective antibody response. And yeah, that's fine. Thank you. Lots of resources that you can take a look at in your own time. I'm not going to really delve into that, so we can just slowly skip through. Yeah, thanks. And we'll just go on to the next slide. And one more. So there's a lot of resources out there that you could direct your patients to. Smart Traveller, as most Australians would know, is pretty good. I use it mainly for seeing what's going on in the countries that I'm going to, but it does provide some information about things like prophylaxis. But this is a UK resource called Travel Health Pro, and it is a little bit better than that, and it provides what vaccines one might get and what other outbreaks are going on, and particular concerns like measles, or sorry, not measles, malaria, and other infectious diseases. Probably COVID is there as well, because that's a big thing at the moment, obviously. Next slide. And yeah, we need to stress other things, preventative measures, particularly safe food and drink choices. I mean, we can only do so much, but it's important to reiterate these things. Insect avoidance, and this is something that we can continually do. Environmental and animal exposures, and other things. Safe sex, risks of bloodborne infections, the pitfalls of insurance as well if they're undertaking a really dangerous activity, and then when to seek help as well. So moving on, I don't know if there's any questions in the chat, so I might just keep moving on. But so travel-associated diarrhea is something that is quite common. We only find a cause half the time. A lot of the time it's a very self-limiting illness that lasts a few days, up to a week, sometimes up to 2 weeks, if we find something. And generally these are because of E. coli or Campylobacter or Salmonella, whether they're typhoidal or non-typhoidal. Some patients might have Vibrio, which could be from water exposure. There's other things like plesiomonas, which is diarrhea from the consumption of raw seafood, and Aeromonas, another waterborne infection. And then on the other spectrum, you've got chronic persistent diarrhea, and this could be things like Giardia. Many years ago, we had a Giardia outbreak in New South Wales, but nothing in recent times. Cryptosporidium and a few other infections there that could be a bit more persistent. Diarrhea does not have to be infective. It could be gastrointestinal related. It might be a sign of a celiac or inflammatory bowel disease or cancer. So don't forget, if they've got persistent symptoms, to screen for other things. And they could have a post-infectious cause or an inflammatory bowel syndrome. And it's not seen that often, but we do see some metastatic seeding from certain infections, particularly Salmonella, where they can cause bowel perforations, Guillain-Barré syndrome, hemolytic uremic syndrome, particularly when they have bloody diarrhea, and it fits with that microangiopathic picture. And they could have a post-infectious arthropathy as well. So in terms of investigations, I'd stress that we need to do some investigations if things are persisting, and simple things such as stool cultures, which can tell us an answer such as, Shigella or Salmonella or Campylobacter. All this stuff would come up, whether it be via PCR or culture. And the blood cultures might be helpful. Sometimes patients with very low-grade fevers will come back with a Campylobacter or a Salmonella result. So it would be worthwhile just adding that to your panel. And particularly when you've got multiple tests, if multiple tests are testing positive, then it's probably likely that you get you got something there. It's not just a viral related illness, but that is the other etiology that it could be. I wouldn't stress ordering viral studies all the time. Yes, you do find the odd norovirus, rotavirus, but given that there's not much in terms of treatment unless they're immunosuppressed, it's not something worth pursuing all the time. In terms of further investigations for persistent diarrhea, it'd be important to get 3 stools for overcystin parasites, and this could include some special stains as well. If they've had recent antibiotic exposure, it would be important to ask that as well, because a lot of patients overseas, particularly when they've gone to subcontinental countries, can access antibiotics just over the counter in their pharmacy. So they may be taking Augmentin or something quite broad, and then that could have just caused a C. diff and led you down a stray. So that's something worth asking and ordering in that case, and then referral to a gastroenterologist if there's malabsorption or other things. There's also some other tests that get done overseas that may not reflect Western practice, and that's like, for example, in terms of typhoid, you can get typhoid serology or Weidell's test, and I did see some of the Nepalese coming back with this, but it's a very poor test and it shouldn't be used in resource-rich countries. So we don't really look at that. We look at cultures and whether they be stool or blood. Next slide. So management. So generally self-limited. I wouldn't really start someone on in a community setting unless they had lots of signs of systemic illness. If they say, look, someone else had typhoid or there was a bit of an outbreak here and there, you might want to give something empirically. And if you were, the treatment of choice is azithromycin. Ciprofloxacin is virtually like 80 to 90% resistance, so it's not worth giving it. So you probably be good with azithro. It'll cover things like Campylobacter as well. Otherwise, if you think that it's not typhoid, you could get away with the ciprofloxacin, and you might want to add some metronidazole for anaerobic coverage. But generally speaking, I would wait for a couple of days. And if they're unwell enough to go to hospital, then that's probably a sign that you need to give them something, or at least do some more tests. I personally stay away from loperamide, at least until the stool tests are taken, and unless they really can't keep fluid down, at that point they're probably going to hospital anyway. So I try and stay clear of azithromycin altogether. Okay, next slide. Yes, so onto a case. Just check if there's any quick questions. No. Okay.
There's a few questions.
Oh, okay. Yeah.
Yeah. So I didn't want to interrupt. So first up from Dr. Rashid, can you please mention the tests which can be done in Australia for each of these conditions? This was talking about kind of dengue and all those other kind of febrile return travelers.
Yeah, so dengue serology is the main one, and that's all you really need to order. It will come back with the antigen, NS1 antigen, and the IgM and things like that, and the microbiologist will give you an interpretation, so you won't need to worry. I think that would be a good starting point. If it fits with dengue, it probably is dengue. You could also order arbovirus serology in general, and that will, depending on which lab, they might send it to somewhere where they can just do a few different arboviruses rather than you naming specific arboviruses. So that could also help. I think I've touched on typhoid a fair bit. Malaria, as I mentioned, a full blood count to begin with. You need to be able to do that. You need the platelets, you need the hemoglobin. Beyond that, a blood film is very important, and a lot of the times, even if you don't order it, one of the lab scientists in the hematology department will actually see malaria at different life cycles and say, hey, this could be malaria, and they might just do an ICT then and there. But otherwise, you can request for the thick and thin films, and also the ICT, which again depends on where you are, but a lot of them will just do it as an unvalidated test and may not release it, but might do it if there is a clinical suspicion. So I think also the other thing to take away is not just to write febrile return traveler, but actually write down what you think it could be, because that really would help the lab in terms of doing these things like malaria testing as well. Was there any other particular infections that anyone wanted me to answer? Otherwise, it might come through.
There was a question around a tropical sprue. Can you please comment?
Oh, I wouldn't be able to comment very much on topical sprue, unfortunately. I've not seen any myself, but I think that would be something that you'd need a lot of suspicion for to go down that path. Yeah, so early on.
There is Dr. Anthony Chan, I think, who put up his hand. I'll just let him put him off mute and see. Yep. All right. Dr. Chan, I'll ask to unmute, and if you could accept that request to unmute. Whilst we're waiting for Dr. Chan, there was one other question around fever and return traveler. What would be the best approach to screen the possibilities down? Should we start with travel areas, then symptoms, then incubation periods? Because most of the time, very early in very early phase, and symptoms can be very vague with just fever.
Yeah, I think in a consultation, like all of that will come out slowly. So, I would, start with symptoms, because it could just be something like influenza, because that is the most common thing that people will experience. And then inevitably you'll find out what country they went to. And it's important then to just have a bit of a duration, or know different periods where they were in different places. So if they've traveled a lot, then just taking a chronological history from what they did where, and just go on. It could take a long time, but I think it's probably best to start with symptoms, because if you think that this is just a flu-like illness, it probably is, and that might be just a good starting point. But if they're negative for COVID, which I'm sure you'll get very quickly, or they might have already done that, they could be so easily tested for respiratory viruses or rapid influenza and come back with that. And I guess if things are persisting but they're not too unwell, then you would probably take a bit more of a very chronological history and go from there, and then refer accordingly. I think I also saw one question about what is an ICT. I tried to refrain from pronouncing the word because it's such a big word, but it's a immunochromatographic test. So it's basically a rapid test to see the count of the malaria there. I think it gives a percentage essentially in terms of the involvement. Yeah.
Right. Great. I think Dr. Anthony Chan has unmuted himself. Dr. Chan, did you want to ask a question to Dr. Colaco? We can't hear you at the moment.
Just in the meantime, another question from Irina saying that our pathology informed us about they don't do thick and thin films anymore. I assume that might be a private lab, but yeah, so I did mention that malaria PCR is also available, and they may do that instead. And that would be relatively useful as well. But they can always refer to a bigger laboratory if there's clinical concern, or a public laboratory. Yeah.
Great. I think Dr. Chan's still having some issues with the mic. Dr. Chan, can you try your mic again? Dr. Rashid has asked, any test for Nipah virus, which is prevalent in South India?
Yeah, actually, there was some talk about this today, because it's actually quite prevalent in Japan. And Japan, we get a lot of travelers from Japan. I think that there may be a PCR, but I don't think it's very widely available to most people. However, I was going to talk about this a bit later, but yeah, no, I don't think it's widely available. So again, it'll probably be a lot on clinical suspicion. Yeah.
Dr. Anthony Chan, if you can talk, try again, but otherwise maybe we'll use the Q&A box and then we'll go on to case 1.
Okay, fantastic. So case 1. So a 69-year-old female presents with generalized abdominal pain, vomiting, chills, and headache after returning from India 4 days prior following a month-long trip. She went to see a GP and was afebrile, and she was advised to take paracetamol, ibuprofen, was given Buscopan, Keflex, and had pathology collected, which revealed a very high CRP at 200 and some deranged LFTs, predominantly transaminitis with an ALT of 131, ALT 88, GGT of 40, and she had some renal impairment with a creatinine of 6. Oh, sorry, she had no renal impairment, sorry, with a creatinine of 60 and eGFR that was normal. She's a diabetic on glimepiride, hypertension on amlodipine. She had 4 COVID vaccines, influenza and childhood vaccines. Her examination was revealed a normal heart sounds, dual heart sounds, clear chest, a soft abdomen with generalized discomfort, and there was no renal angle tenderness. So next slide. What do we think is the likely cause here?
Now, I believe this is a poll question, so I'll just launch the poll. Oh, yep, it's just been launched. So we'll be able to see the results in a little while. I'll just leave it up there for a minute so that everyone has a chance to put in their best guess. All right, we're halfway there. Another 40 responses or so to go. I'll give it another 15 seconds. All right, I've put up the results there.
Oh, I can't really see the results, but
so I'll describe the results to you.
okay, yeah.
About 35% sedentaric fever, 4% influenza, 54% Hep A, 6% gram-negative septicemia, and 1% COVID-19.
Yeah, that's interesting. Look, it could be many things, really. And I think, you know, these are real cases, so I obviously know what happened in the end. And you do need to test for all of them. I mean, look, Hep A is possible, but we don't see a lot of it from return travelers in, well, we don't see a lot of it, just full stop, because I think a lot of patients have received Hep A vaccination in their time, and really, like, yeah, we just don't see a lot of it, unfortunately. We like the IgGs are generally positive even here in Australia, because of vaccination. So I think it's less likely. The other things, I suppose, I get why people chose it, mainly because of the LFT derangements, but all of these can cause LFT derangements. So this was actually a case of enteric fever, where she was actually bacteremic as well as had Salmonella typhi in her stool. So technically gram-negative septicemia would be correct as well. And this was a much more milder case of typhoid. I mean, she had some abdominal discomfort, but other than that, not terribly unwell. However, she did get quite a few days of intravenous therapy. So I'll just move on to what enteric fever is. If we could just go back maybe one slide. Yeah. So enteric fever encompasses both typhoid and paratyphoid. We see 22 million cases around the world, and there's 200,000 related deaths, and there's particularly in India, in Africa, and other countries where they see a lot of cases. There is also, in addition to that, 6 million paratyphoid cases. So quite a huge burden of this overall disease. Greatest risk to travelers in South Asia, but other countries, as I mentioned. And it's really around poor sanitation, untreated drinking water, and other practices that we would normally otherwise do without even thinking twice, such as drinking, putting ice in our water, or eating vegetables that have been washed under the taps. So these are the things that actually might be harboring some of these Salmonella typhi. Clinical features, so prolonged fevers, diaphoresis, bad headaches, generally feeling unwell, diarrhea, anorexia, and weight loss. And the incubation period can be 8 to 14 days, so it could be really difficult when the patient is gone for a long period of time, but also could be really difficult if they spend a very short period of time and then have come back to or moved on to another country which doesn't have endemic disease. But the symptoms appear generally pretty early on. Next slide. So prevention is very important. Washing your hands with soap and water, avoiding uncooked foods. What you drink is important. Some even would boil water before brushing their teeth. Avoiding ice, avoiding street food, and ensuring hot food is thoroughly cooked through and eaten when hot. And then you can get a typhoid vaccine, which is combined with hepatitis A every 3 years. And then after you've had 2 typhoid vaccines, 2 combination vaccines, you can just get the typhoid alone every 3 years. Unfortunately, there's no currently available paratyphoid vaccine, but I think it's in phase 2 studies, so watch this space. Next slide. So blood cultures, stool cultures, urine culture is actually sometimes found it. It's not a contaminant. If you see it, it could be a pathogen, and there's no role of serology. And the treatment generally is inpatient or needs to be admitted for ceftriaxone. But if they're really systemically well, it could mean a couple of things. It could be that they're chronically colonized with typhoid. It could mean that they're partially treated from overseas. So that's something to also consider. But I think in that setting, which I have had the odd call or two, it's probably best to just refer on. There's developing typhoid resistance over time in the graph, which is not very easily seen, but that's basically illustrating the resistance to ciprofloxacin, so fluoroquinolones from early 1999 to 2017. So it's gone up from 20% to, this says about 75, but it's probably closer to 90 by now. Yeah, so try and avoid Cipro. And also consider additional testing, such as for hepatitis, HIV, if they've got LFT derangement. Cool. We'll move on to case 2. So case 2 is a 28-year-old female, again, a real case, becomes unwell. And the day after returning from a month-long holiday in Thailand, she complains of a fever with severe headache, myalgia and sore eyes. On the 4th day, her temperature settles, but then she gets a generalized rash. She's pyrexial, low grade though, heart rate 75, normotensive, diffuse macular rash over the chest and abdomen. The rest of the examination is pretty unremarkable. She's got a normal hemoglobin, leukocytes count, and platelets, and her blood film for malaria parasites are negative. So what could she have?
So I've launched this, the questionnaire whilst you were talking. So there's already quite a lot of answers, but we'll just give it a bit longer because there's still about 60 attendees to answer.
Yeah.
I'll give it 15 more seconds. We're halfway mark. 50 attendees have answered. All right, there's a few chat comments that unfortunately the poll didn't launch for them, but
Yeah.
that's okay. We'll talk through the answers as we end the poll.
Okay,
All right,
sure.
there we are. Can you see the results?
Maybe I have to open this up. No, it just has the results. I mean, it just has the options and then it's gone.
Okay. All right, technical difficulties. So I'll read through the results. So
Yeah.
67 responses, 4% said enteric fever, 12% scrub typhus, 9% malaria, 70% dengue,
Ooh.
and 4% leptospirosis.
Yeah, so that's spot on. I think again, the country is very important. So Southeast Asia, we've got things like generalized myalgias and rash. Again, these non-specific symptoms with low-grade fevers all sort of point towards something like dengue. Malaria just doesn't quite fit. Yes, it's a month-long holiday, but it's just not quite the right fit. I don't think I've seen any typhoid in Thailand, and yeah, I don't think scrub typhus would fit here, nor would leptospirosis. So I think those that had the dengue were correct. So I'm going to talk about dengue, if you can go to the next slide, and just some of the other infections as well in that family. So it's a flavivirus, which includes things like Zika, yellow fever, and Japanese encephalitis. And then its close neighbor is chikungunya, which is part of the alpha virus family, which includes things like Ross River and Barmah Forest, which we have a bit of in Australia. And it's in tropical and subtropical regions in the Pacific. It's associated with a couple of different mosquito vectors. So the Aedes aegypti is the most common one. It may occur from the bite, well, it does occur mostly from the bite of an infected mosquito, but could occur through other things, particularly overseas where they might have issues with blood transfusion, organ transplantation, needle stick injuries, and so forth. And I've never heard of vertical transmission, but it is possible if they were viremic at delivery. Complications. So this patient is a very mild sounding patient in terms of dengue, but dengue shock syndrome is something that we're particularly concerned about. Things like capillary leak syndrome, myocarditis, bradycardia. They can get hepatitis, encephalopathy, all sorts of weird and wonderful things, but these are all on subsequent exposure to dengue. So it's always important to say, have you had dengue before? Because if you have, then you start to see some of these things in these blood abnormalities. Next slide. So a very short incubation period compared to some of the other diseases. Many can be asymptomatic, minor symptoms. Some can have fevers. But the classic features are the fevers, the myalgias, the headache, and they might have some GI disturbance as well. And they have this erythematous rash, particularly in the initial febrile phase, bright red, scatters clear spots, and it will go after some time. And they tend to lose their fever. They defervesce in about 4 to 5 days, but they can be really tired and so forth. So it might take quite a long time for them to get better. Next slide. So lots of investigations. If you could just click a couple more times. Yeah. Oh, okay, sure. So the best test for this is, well, there's a few tests you firstly do. So leukopenia, so you'll see on a full blood count, low white cells, low platelets. They could have a bit of a coagulopathy with increased APTT, so worthwhile considering some coags. They might have some LFT derangement. Now, this diagram explains the text underneath it much better than anything else. So essentially, when they're viremic, it's important to consider that you can do a dengue PCR, and that will give you a nice quick answer. You can do the dengue serology, which will give you the things like the NS1, and that'll be positive really early on in the illness. but the IgM, the IgG is something that will come on a bit later on. So if it's negative initially in terms of serology and your NS1 is positive and you've done the workup in very early dengue, which is probably unlikely if they've come from overseas, then it's not harmful to just repeat the serology in a couple of days and see if anything has changed. And some things disappear after a period of time. So your NS1 antigen will disappear after 7 days, and the utility of your PCR will be fairly useless after 5 days. So it's important to consider this. It's also important to consider cross-reactivity with other viruses in their family as well. And then management-wise, it's very much supportive. So it's things like paracetamol or non-steroidals, monitoring of their platelets, particularly if they've got dengue hemorrhagic fever, referral to hospital if there's any severe signs, preventative strategies in the future, which may be difficult. There is a vaccine that is mainly for people living in endemic countries. That's a live attenuated vaccine. So that is something to consider as well. Okay, next slide, please. Yeah, okay, so we're on to case 3. So case 3 is a 33-year-old male that presents with fevers, headache, vomiting, and diarrhea after returning from Sierra Leone. So the timeline is essentially that this guy has gone from Sydney in December to KL to Istanbul to get to Freetown, which is, I believe, the capital of Sierra Leone. And then he spent about a month there and then headed back via a similar sort of route through Bali instead. Just 3 days before or 2 days before leaving, he started to get fatigue, lightheadedness, and headaches. He had persistent fevers, had some vomiting, diarrhea, didn't have muscle aches and pains, no coryzal or lower urinary tract symptoms, no abdominal pain. Very extensive extensive activities history. This was actually taken when he presented to emergency, and this was taken virtually in its entirety on the first visit. So very comprehensive. So he lives with his wife and sister in Freetown. He spent 4 hours in a rural village, but was petrified of drinking any water or eating there. He had no exposure to hospitals or sick people, home-cooked meals, bottled water, no unpasteurized products, but he was bitten by mosquitoes multiple times. No contact with animals, no intercourse apart from with his wife, and no recreational drug exposure. So what is the likely diagnosis here?
I'll launch the poll now.
Yep.
Hopefully everyone can see it this time. I've just launched that. Whilst everyone's answering the poll, there were a few questions that came through about dengue. There was one about doesn't dengue cause low platelets? I think that was maybe on the case there wasn't a low platelets.
It's a bit variable. I think it does happen a lot of the times. Some of these patients may have a bit of a higher platelet count to begin with, and so it might still remain within the normal range unless you look at what the trend is going on, what the trend is doing. So it's worth looking at that as well. The other question about dengue, we don't really see any dengue in Australia. It's mainly imported dengue, but things like Ross River and Barmah Forest are what we do see more of in, I think, areas of Queensland and places like the Northern Territory and things. Yeah.
All right. And was there a mosquito elimination program of some sort?
Yeah, I think there was at some point. And actually, interestingly about the mosquitoes and how Japanese encephalitis is monitored and how we knew things were going to get or start to come back is because there is this great monitoring program where they have traps for mosquitoes all around different areas, and they just basically look at it and see what kind of viruses are there, and then that'll inform things. So I think the traps had found JE many weeks to months before we actually just had our cases in the last few weeks. And similarly, when we did that retrospective analysis in the first sort of wave, we were finding a lot of it in the mosquito population. Yeah. So I can't see the results again.
Oh, okay. Yeah. So the results were, 73 responses, 5% thought leishmaniasis, 3% scrub typhus, 64% malaria, 4% dengue, 8% African trypanosomiasis, and 15% viral hemorrhagic fever, e.g. Ebola.
Yeah. So look, it's interesting. I think this is just a bit of an example where common things present commonly. And yes, the guys in West Africa, there's lots of Ebola around. That said, there hasn't been a case for the last couple of months there because they've virtually eradicated it. The commonest thing is that this guy has malaria and it just fits. He also had a background history of malaria, but I couldn't tell you that because otherwise it'll just pretty much give things away. So yeah, this guy had malaria. So we will just move on to malaria now. So basically it's a parasite that infects red blood cells. There's 4 main species that can cause different kinds of diseases, but we really see just falciparum and vivax, but it depends where you go, but the ones that we commonly see are those ones. It's got a very complex life cycle, which I won't bore you with the details, but it's basically through bites of the infected female Anopheles mosquito, most cases in sub-Saharan Africa, but we do see it in some Pacific countries. And generally, the classic, medical student sort of thing you remember is that they have cyclical fevers. So that means every 24 hours they get fevers. Return travelers from endemic countries, and it's hard to distinguish this from non-malarial related conditions. So it's just something that you would probably need to base on whether they had chemoprophylaxis, whether they were taking it, and which countries they actually went to as well. So in terms of the next slide, so in tests include full blood count. You might see some thrombocytopenia, but a lot of these conditions, even severe sepsis, can cause that. The blood film might pick up the parasites. Lots of different tests that can be done, and I've touched on them quite a few times today. The management depends on the type of the species. So sometimes you can get really, really severe malaria where you've got counts of like 10%, 5%. That's really, really significant disease. And they probably have some degree of end organ dysfunction. They might not be able to swallow the tablet. So that's when we consider intravenous artemisinin. But other times, I think this guy had a very boring count. His was like less than 0.01. And he wasn't actually pre-treated prior. And he also had falciparum. Noalesi and Vivax can cause severe disease. Things like Vivax do require primaquine, which is another medication at a certain time point after checking for G6PD. And then the rest of it is essentially supportive care. They can become hypoglycemic. They can have pulmonary and cerebral complications as well. Yeah. Okay. So that's about it. Is there any other questions? There was one here. Why is it advised to vaccinate for Japanese bee and encephalitis only if the stay is at least 4 weeks in the area where it is prevalent? I'm not sure if that refers to just in Australia or if that is for overseas, but I would follow the guidelines. So if their stay is a long period of time, then and they're traveling to areas with high burdens of mosquitoes, then I think that would be a reason to vaccinate. But I think, yeah, I'd follow the guidelines. Yeah.
I think that's a common guideline on CDC about balancing risk versus benefit of deciding whether to vaccinate for Japanese encephalitis in areas like going to Thailand.
Yeah. And also, it's not cheap. A lot of these patients may not want to get these vaccines. And there was a time, particularly in Australia, where everyone wanted, all the farmers and people living out there, the vaccines were prioritized for these people. So it might not, access is an issue sometimes as well. So it might be one to avoid. And again, it's if in a short period of time, yeah, it's less likely, I suppose, if they can take other measures as well. Yeah. Okay, that's no more questions, right?
All right. So
Yep.
I think this is a slide.
Yep.
This is a poll as well, is it?
Yeah. Yeah. Oh, but this is just basically giving the answer away. So we might skip this question, but basically it's 5 infectious causes of a bite. I think the main thing to take away is that there are tons and tons of infections caused by bites. And essentially you just need to break them down into different categories. So mosquito would be a large one. Then potentially things like cats. Toxoplasmosis, Bartonella, Pasteurella, those sort of things would be associated with them. Dogs, I've got the Capnocytophaga carnimoris, but they also could have other things in their teeth, such as just strep, like we might. And then, yeah, there's a lot of weird and wonderful things like rabies and tularemia and all these sort of things that could occur as well. So we might move on to the next question then. Hopefully it doesn't pop up. But yeah.
Dr. Colaco, did you want us to put up the next poll before we release the answers? Because
yes,
that may
please.
also have the slides. Thank you.
Please.
Yep.
So we have released the question.
Yeah.
Name
Actually, I think these ones don't actually have the answer, so I'll just be yeah, perfect.
So I've got lots of answers coming in. Now, for the short answer polls, we don't actually see the individual answers.
Oh, okay.
Yeah, I can see how many people have answered, which is helpful.
Yeah.
And it contributes to our evidence for the reviewing performance kind of CPD hours. So
good.
That's why we're collecting this. Yeah.
Oh, good. So yeah, so can we, does the question launch then, or?
Yep. So the question has launched. It says name 2 tests to diagnose
Oh,
typhoid.
okay. Oh, can the slide be put up?
Yeah.
Yeah.
Cool.
Yeah. Yeah, perfect. So yeah, so basically any of these 3 tests, it's mainly blood and stool, but as I alluded to earlier, the urine can actually culture Salmonella typhi, so that could be your answer. And I think another pearl would be also if seeing Staphylococcus aureus in the urine. It's another example of if you find that particular organism in the urine, it's not actually a contaminant or just on the skin. It might be a sign that they actually have a bacteremia, and then you could start looking that way. So similarly with typhoid, if you find it in the urine, because for some reason they're saying they have lower abdominal pain, well, might be a sign that you might need to do a blood culture to see, particularly if they have low-grade fevers. Yeah. Cool. All right, on to question 3. Oh, yeah. Yep. Which of the following conditions are not vaccine preventable?
Yep. So I've launched the poll. I'll give a minute or so. So just for everyone, it's multi-choice, so you can tick more than one. Good. Let's give another 20 seconds. We've got good response rates. Right, I think that's plateaued. Okay, I'll end the poll. Not sure if you can see the results.
Oh, I
but-
can actually now.
Oh,
I
you
don't know
can this
why.
time?
That's
Okay,
yeah,
that's great.
okay. So yeah, so it's interesting. Dengue does have a vaccine available that I mentioned. Influenza, as most people know, has a vaccine, which basically mirrors the prominent strains in the northern hemisphere. So that might explain why I had influenza despite having my vaccine in the southern hemisphere, because that's what they're going to model the new vaccine off. Hepatitis A has a vaccine, so that's good. Malaria actually has a vaccine that's only recommended to children per the World Health Organization in sub-Saharan Africa. It's not something that is widely broadcast, but it is there, and it just was approved in October of 2021. So it's pretty hot off the press, but not something we would be advising for our patients. Paratyphoid does not have a vaccine, and that's something that is in early phases of trials and might be of use in the future. And Japanese encephalitis does. So yeah, that was pretty well answered, I think. Good. Okay. I think, yeah, so there's a couple more slides. So some final thoughts. Basically, this is to demonstrate that we can't forget about things like COVID and influenza. So this was taken 3 weeks apart. For those not in New South Wales, Dr. Chant, our Chief Health Officer, sends this to a lot of practitioners. I'm not sure if it's GPs included, but and I'm not sure why I get this. I used to work for the Ministry of Health, so that might explain why I'm on this mailing list, but I think a lot of people get it. And it essentially tells you about positivity rates, what are the prominent variants, and then as you can see, they change. 3 weeks in, then they're not talking about some of the variants that they were talking about before. They talk about the hospitalizations and the amount of deaths. So there's quite a lot. Like in early February, you're looking at 90 per week. It was down to about 48, in last week, or the week before that, and more data will be released tomorrow. So there's quite a lot of COVID activity when you think about it. 6,000 diagnosed in a week. That's a lot more than any flu outbreak that we've ever had. And then speaking of the flu, influenza, low level PCR positivity, but saw lots of cases in the Northern Hemisphere. And look, it's basically predicting that we could see an earlier start to our influenza season, but we need to just monitor this. Next slide. Okay, so a couple of other things just for interest's sake. This is a site called ProMed, which is, I think, an international collaboration around the world that tells you about all these weird and wonderful viruses and infections that are happening around the globe. And it's something like this that COVID would have initially been put on, monkeypox would have been initially put on, and people started to see it, and it gained a lot of traction. So if you could go to the next slide, Nazia. Yeah. So essentially, like, it is really thorough. Like, if you subscribe to this, they'll send you as many as 10, 20 emails a day, or you might want to reduce it. And gives you a great map of where things are happening. I'm sure someone will ask me what's happening in Australia. Well, one of those red dots is to reflect Japanese encephalitis, and another red dot is to represent a fatal case of Murray Valley encephalitis. So I just sent this through like a few hours ago, so it's very recent. And then you can see all sorts of different things like Nipah, as someone mentioned, LAS is still going on, and then some other stuff that may not be as relevant. And then there's tons and tons of COVID stuff. So COVID variants might be published here very early. And then last slide. So this is me, a bit of a shout out to what I do once a week at Westmead. So Westmead in Sydney is essentially our big centre in New South Wales, where we have a biocontainment facility. So anyone that comes from overseas that has a viral hemorrhagic fever concern or virtually confirmed would come through Westmead and would be admitted under one of our care. And so we're basically trained in the PPE, as well as handling of specimens, taking of specimens, you name it. I actually spent a whole day training today. This photo is not from today, but essentially was wearing the same thing. I'm wearing something called PAPA, which is this high-tech face mask, which will allow me to breathe for hours and hours, much more comfortably than a normal face mask. But roughly speaking, this could be something that I'd use for a respiratory airborne sort of procedure. So not that I know how to bronch, but if an intensivist or a respiratory physician needed to bronch, they would use this sort of PPE. Whereas I'd be wearing something a bit different if I was dealing with a viral hemorrhagic fever. This on the second picture is a test that we can do at Westmead called a global fever panel. It's a type of biofire that some people might be familiar with, and we can get a result on this test, which could be a blood test, essentially in 45 minutes. So we would collect the blood and then go to the next room, perform this test, come back 45 minutes later and be able to confidently say a patient has or does not have any of these sort of things. Unfortunately, we used it 5 times and we haven't got anything on this list. I mean, some of these things are a bit more obvious than others, like malaria is there, so we can get a really quick result on malaria. We can get typhoid there as well. But yeah, if we're starting to get some of those on the left side, we'd be very, very concerned. So we can do this really quickly. If you're suspecting it, particularly if you're in Sydney, you'd probably just call Westmead Hospital Switch. They'll put you through to one of us and we will say, yep, send them across, and they might go straight to this center. So this is actually one of the rooms. It's a humongous room, but it's required for all sorts of things. So surgeons have come here and operated. We had monkeypox patients in here. There's all sorts of things we can do here, and it's reserved for these sort of patients. So I think that was my last slide. I'm more than happy to take any questions should anyone have any.
Thanks so much, Dr. Colaco. Does anyone have any questions? Either put up your hands and I'll unmute you, or we can use the Q&A box as well. Any final questions before we run through the final reviewing performance reflection questions, which you can fill in online using that QR code on your screen.
I'll just make one final comment, which I think was about the Nipah virus. How do we test? A lot of these viruses that are overseas, there are probably dedicated PCR tests. I do know that there is one for Nipah, but generally speaking, private laboratories would not do this. It would have to be huge reference laboratories in each of the states, and it would really be up to that you can talk to your microbiologist and they'll happily give you some of these or tell you what's available, or they'll do some digging and say, oh, we can refer it on to here and here and so forth, and then it gets done. And that's essentially how Japanese encephalitis testing started. At Westmead we became the center that does it, and then slowly but surely some other sites took over. So ask it and you probably will receive if you really want something. Yeah.
All right, thank you. I've posted the link below for our attendees. I'm also going to post it in the answers as well. Oh, we do have one question from Dr. Rashid about any thoughts about chronic EBV infection? Any investigations other than EBV PCR?
Yeah, so look, this is a tricky one because I think for starters, you'd need to quantify the EBV. And so to be a quantitative PCR rather than just a qualitative PCR. Serology is almost useless in this setting. What you really need to be concerned about is, does this patient have some sort of lymphoproliferative disease, hematological malignancy? And that's really what you've got to be searching for. Or are they on tons of immunosuppression, particularly high-dose steroids? And is that why they're essentially getting EBV? We can't really do anything if it's not in an immunosuppressed setting. We get asked this all the time. Viral loads are 3,000, 4,000, and we go, well, reduce the immunosuppression or that's it. But generally speaking, they don't get much in terms of LFT derangement at that sort of levels. There's a lot of things that can cross-react, like CMV. So it'd be worth exploring that option as well with a viral load and looking for end organ dysfunction. But yeah, if you see chronic high viral loads of EBV and there's any concern for a malignancy, that's really where you should be heading down, because they can get rituximab and all sorts of other things from that point of view.
Thanks, Clinton. All right, any final questions before we finish up for the evening? Well,
Meanwhile, I'm
thanks.
happy to share the QR code. Sorry,
Yep.
Dr. Ray.
Yeah.
I'm happy to share the QR code as well for people who are joining from their desktops.
Thanks so much, Dr. Colaco. That was really, really informative. And hopefully we don't have too many weird and wonderful diseases to send your way. But if we do, we know who to contact.
Thank you very much.
Thanks, Clinton. All right, so for everyone, the QR code, if you're on your computer, otherwise I've put the link into the chat to complete the basically the reviewing performance questions, where you reflect on how it may change your practice from Clinton's session, and that way we can document and have evidence for submitting the reviewing performance CPD hours. Hope you all found tonight a great experience. It's our inaugural session for this new CPD year, and we will be putting out more information about how we plan to support everyone with with the measuring outcomes activities. Of course, the RACGP and ACRM both have their own resources for how to meet some of these CPD hours as well. The session has been recorded. There's a few questions around that, so you can watch the recording, do your own self-reflection, and then you can still self-log your reviewing performance hours in addition to the educational activity hours. So if you just contact the gp@telecare.com.au email, we can point you to where the recordings are, and Nazia can help you out as well. So if you could send an email, that would be fantastic, just so that we've got an email to send you the link to. All right, wishing everyone a great evening. We'll leave up the QR code and the links, and again, thanking our speakers, Dr. Clinton Colaco and Dr. Vivien Li tonight. And also awesome work from Nazia for setting this up. She's done an amazing amount of work to set up the CPD program. So thank you, Nazia, as well for your
Thank you, Dr. Ray.
valuable contributions. All right, wishing everyone a great evening. We'll leave the slide on though, so feel free to keep scanning the QR code.
Oh, sorry.
Oh, yep.
Yep, I'll just be back with that 1 second. Yes.
Yeah. Oh, the email was gp@telecare.com.au. Oh, sorry all. There was one more announcement that I forgot to mention, which is that we actually do have a face-to-face event in Melbourne about a face-to-face CPD event on the 21st of March, and it is about examination of the newborn, and we will actually have a live mannequin to help with demonstrating the examination of newborn, which will be conducted by Dr. Hack, who's a pediatrician with an special interest. So please feel free to sign up on our website on Eventbrite if you're in Melbourne, and it will be available virtually, I believe. Is that right, Nazia?
Yes, correct. It will be a hybrid.
Hybrid,
So anyone who's unable to attend it from Melbourne or Victoria is most likely to welcome, like we are welcoming them to just join it online. Otherwise, we would love to see you face to face, which is in Box Hill.
Absolutely. And of course, examination of newborn, lots to kind of learn in person. So definitely highly recommended. If you do have to make a little bit of a trek, still, I think it's always worthwhile doing that in person. But if not, then virtually is still a very valuable experience. And thanks, Nazia. Sorry, I forgot to mention that earlier on.
Thank you, Ray. It's perfectly fine.
Yeah.
And thank you all the GPs who've had amazing comments and compliments for us. Thank you so much. It means a lot. It gives us such inspiration to carry on such CPD events in the future.
Absolutely. Thanks, Nazia. So I'll leave the QR code and the links there for everyone, just in case you do need the links. But just a reminder, do sign up for the face-to-face event, and we will also have a third session in late March as well on the Eventbrite page. Have a good night, all.
Thank you, Dr. Ray. Thank you for all the efforts. Good night. For everyone who's still online, the QR code will still be available for the next 5 minutes. So feel free to scan. We're still here. We will end the webinar officially at 9 o'clock. Thank you so much and have a lovely night. For any of us who's still attending, still online, we just have another 1 minute to go, and we shall be ending the webinar. Thank you so much. Thank you, everyone, and have a good night.